Let's pause for a moment and look back at what we've seen in the preceding lectures. They've tried to develop a rather rich view of a patient informed by a variety of evolutionary perspectives. I'm going to recast some of the take-home points in different words to try to get across what I think are the most important insights here. The first is that patients are mosaics of parts that have very different ages. Some of the very oldest parts of our bodies, like our intermediate metabolism, are very precise, very efficient, and they have been shaped by billions of selective events. They are also very hard to change. And some of the most recent responses have not yet had time to adapt, and they can produce maladaptive mismatches. We've seen some of those with things like the hygiene hypothesis and the microbiome. Patients who have different ethnicities, different geographical origins, have genes that experience different histories of exposure to disease and to diet. They vary in ability to resist disease and to metabolize drugs. That is why we need to have good genetic information, if we can afford it, so that we can personalize medicine. Humans have only very recently evolved altricial young, that is, young that are helpless at birth, short interbirth intervals, and menopause. These conditions are not yet as precise or as elegantly designed as ancient traits, simply because they have been shaped by many fewer selective events. You can think of the number of selective events as being something like how coarse the sandpaper is. If there have been billions of events, it's very fine sandpaper, and it's practically down to lens grinding compound in terms of how smooth and beautiful it can make something. But if there are just a few events, it's either very coarse sandpaper or it's more like a hammer and a chisel, and you get a very rough shaping of the adaptation. A fourth point is that patients not only have an evolutionary history, they have a developmental history. And they react to diet, exercise, and disease with plastic responses. Among their most important experiences are the ones that happen very early in life, things that happen when they are in utero, during childbirth, and just after childbirth. That is when things like the difference between C-sections and vaginal delivery and breastfeeding and formula feeding and the use of antibiotics or not can make a big difference to the microbiome and then to the risk of atopies and autoimmune disease later in life. Another point that we encounter repeatedly in evolutionary medicine is that patients are bundles of trade-offs. These trade-offs between traits were assembled by evolution out of whatever variation there was that happened to be good to use at the time. And it had side effects. So those side effects have accumulated over evolutionary history. If there's a trade-off, then a change in one trait is going to be linked to changes in other traits. It's going to be linked genetically, developmentally, and physiologically. It's almost impossible to change one thing in a patient without changing other things. It's worth emphasizing that early experience makes a difference. Nutrition in utero and in infancy affects risk of cardiovascular disease, type 2 diabetes, and obesity decades later. And this has impact not only on how pediatricians think about taking care of their young, it has impact on social policy and on the benefits of preschool programs, on lunch in school, on all sorts of things, where setting children up early in life to be in good shape is going to save an awful lot of money and a lot of suffering later on. The microbiome is something that is getting more and more attention all the time because it appears to have so many roles, and we just keep discovering more of them. The microbiome is affected by C-sections, breastfeeding, and antibiotics, and that has consequences for things like autoimmune disease and obesity. And I know I am repeating myself, but I think it's really worth hammering home that events early in life have disproportionate impact on the entire rest of life. And then one of the big important messages of evolutionary biology, not just for doctors, but for everyone, is that we were not selected to age and die, but we do age because we've been selected for reproductive performance. And reproduction has costs in maintenance and in mortality that were worth paying, because people who reproduced better got more genes into the next generation, even if they died sooner. And this, the evolutionary theory of aging, is actually the explanation for why our bodies are so susceptible to degenerative disease, and why it is that we're not better protected against the insults and injuries that happen to us as we get older.